Bismillah ar-Rahman ar-Rahim. Welcome all colleagues to the fifth session of step-by-step CESR application to get the specialist registration in United Kingdom. So welcome all on board, and today will be the second session or the second discussion on non-CCT CESR in cardiothoracic anesthesia. I would like to welcome Professor Hisham Hosni. He is anesthesia and critical care consultant and professor of cardiothoracic anesthesia in Cairo University Hospitals. He's a consultant anesthetist and intensivist in Essex, Mid and South Essex University Hospital, Essex Cardiothoracic Center in the Middle and Southeast University Hospitals Group Foundation Trust in United Kingdom, and he's a former consultant of anesthesia at Royal Brompton Hospital, and he worked as well as a fellow in Harefield Hospitals and Freeman Hospitals in the United Kingdom. Dr. Hisham Hosni is a successful applicant in cardiothoracic anesthesia as per the new regulations and per the new setup. So he will be, I'm sure, an add to our previous discussion with Dr. Amr El-Sisi, who presented his cardiothoracic anesthesia CESR application experience. But as you know, if you attended that lecture, that it was an old application, and he applied for non-CCT, for regular CCT anesthesia, and then they advised him to go for the non-CCT application pathway for cardiothoracic anesthesia, given his own experience in that field. So it was not like a standard application form. So today we are getting an add-on or addition to that experience with Prof. Hisham Hosni. So a virtual bunch of flowers, Prof. Hisham, for yourself, and thanks very much for accepting. Thank you very much. To be with us today in the weekend. I know it's hard to do that during the weekends, but thanks very much. I do really appreciate that.
My pleasure.
Yeah, as usual, my colleagues in this session, your questions are always welcome verbally at the end of this lecture or Professor Hisham's lecture, and you're always welcome as well to write your comments in the chat box if you wish. I'd like to highlight this point all the time, as you used to have. I don't have any conflict of interest apart from I am the founder of Saving Lives Academy, and all these are in the YouTube channel, and this YouTube channel is monetized, as you know. And I declared that multiple times before, so nothing new. I have no legal responsibility for any evidence or advice given herein. You know, it's a dynamic process, so make sure that you review the latest guidelines. Your questions are so welcome at the end of this session. Professor Hisham, you can start to share your presentation, please, and thank you.
Okay. Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Walid, for the presentation and for the invitation to share my experience with the non-CCT cardiothoracic CESR. I hope, as a fresh applicant or fresh graduate from the CESR route, that I hope to be beneficial, and I hope that my information will be the most recent that I can possibly provide for our colleagues who are applying as well for the non-CCT cardiothoracic route. As you mentioned, I'm a professor of anesthesiology and intensive care at Cairo University, and I'm also a consultant of cardiothoracic anesthesia at Essex Cardiothoracic Center. I actually putting my affiliation here intentionally because this will help, moreover, when we try to explain how things go forward when you're applying for the non-CCT cardiothoracic center, cardiothoracic CESR, because we are coming from different backgrounds, we are coming from different places, different job titles, different training programs. I hope by the end of this presentation, that we will be able to have a clear or clearer impression about how to proceed with the CESR application in cardiothoracic subspecialty. I thought instead of having just a narrative virtual presentation, I would actually took a snapshots from my report at the end. So this is the report I received from the GMC with their recommendations and with the conclusion at the end for my application. And the first point to stress on is the eligibility. Eligibility for non-CCT cardiothoracic CESR is quite flexible, I would say. So if you notice over here, we have two routes, or we need two requirements. The first requirement is the question, has the applicant specialist medical qualification in the subspecialty, or has the applicant has a special medical training? Special medical qualifications mean that we have that the applicant had sit for an exam in cardiothoracic anesthesia, and this exam is acknowledged by the GMC and acknowledged by the Royal College. And luckily enough, the applicant managed to pass this exam and be granted with a degree in cardiothoracic anesthesia. On the other hand, most of us are kind of experts in the field. So I would say the other route is the more suitable one, which is special medical training. And this was the route which the GMC said, yes, this is applicable for us. We approve it. Then you can go through the non-CCT CESR. And then there is a phrase here about the evaluation requirements, that against any of these two requirements, then they can decide, are you eligible or not? And I believe this is the most critical point in the application itself. Just to say that I have enough experience in cardiothoracic anesthesia, so I can apply for this post or for this CESR route, non-CCT route. And for the GMC to have an experience in cardiothoracic anesthesia is to have to fulfill all these 4 points. You have to have more than 6 months of experience in a full-time job at a trainee level outside the UK. And here sometimes there was a little bit of confusion, I would say, because it's not about how much experience you have. It's about how can you document this experience and how can you formulate your paperwork and documents in a form that the GMC accepts. So definitely we have more than 6 months of experience as cardiac anesthetists, even, and it has to be outside the UK as a top at a full-time job. The two issues here are, it has to be a trainee level. You have to have training in cardiothoracic anesthesia, not just working as a consultant of cardiothoracic anesthesia. You have to prove to the GMC that you received a training in this specialty. And this training or this training job was a full-time job. Some countries have what we call like fellowships in cardiothoracic anesthesia, and this is very well accepted. Some countries have jobs when you have the I would say the title of a specialist or registrar or whatever terminology they can provide, but which reflects at the end that we are talking about a trainee level, not a consultant level job. And at the end, this has to be outside the UK. So even if you have enough experience of cardiothoracic anesthesia within the UK, this does not count to be eligible for the this route to start with. And here I can reflect back to my application. So because I'm a professor of anesthesia at Cairo University, and in the application, you have to submit all your job titles since the graduation until the current job. So all of them goes into the academic route of anesthetic jobs, starting from the resident, followed by assistant lecturer, assistant professor, or associate professor, and the end professor. But nothing in my paperwork says that I am a professor of cardiothoracic anesthesia. And here came the first reply from the GMC, and they said, why don't you apply for a general CESR rather than a cardiothoracic non-CCT CESR? Because certificate-wise, I have the European Diploma of Anaesthesia and Intensive Care. From the job titles that I had before outside the UK, they were all anesthetic, but nothing says that is a cardiothoracic anesthesia. And then again, I replied that all my evidence, all my recent evidence is completely cardiac, and applying for a non-CCT general anesthetic would definitely be a complete failure. Because first, I don't have enough recent evidence. All my evidence is quite old in this perspective. And the other thing, I've been doing cardiac for quite a very long time. So it will never be successful if I apply for a non-CCT outside the cardiothoracic. Then they accepted this, and then we moved forward to the evidence itself. The first domain that we speak about, as I think you all know, it's the knowledge, skills, and performance. And over here, you have two requirements. The first question is, has the applicant demonstrated that they have full range and depth and breadth of experience and the skills? And the second question, has the applicant demonstrated the application of that knowledge and experience into practice? And then when you submit your evidence, luckily enough, the GMC and the Royal College, they have something like a manual that you can refer to. So what do they recognize as an evidence? What do they accept? So what we need over here is to have what's equivalent to the higher and advanced cardiothoracic anesthesia training, and to have a cut form for this, which is the completion of unit training forms in this subspecialty, namely cardiothoracic anesthesia. The good thing about this is your non-cardiothoracic anesthesia training is acceptable even if it's more than 5 years old. So it still counts. And this is clearly stated in the application process. They know that applicants in subspecialty, speaking about cardiothoracic in this case, or any other subspecialty like pain or whatever, they definitely finished their general anesthetic training, and then they subspecialized in this subspecialty. Over here is the cardiothoracic anesthesia, and they have been doing this for many years. And this really saves your neck from having to go back to finish whatever modules the non-CCT general anesthetic can put you through. So they will acknowledge that you finished your obstetrics, your neuro, your pediatrics, even if it's more than 5 years old when the time you apply and you submit your application. So the good thing about it is, yes, they accept more than 5 years old evidence. Maybe the dark side that all your evidence, all your recent evidence, all the 800 to 1,000 pages, or what they say on the website, should be in cardiothoracic anesthesia mainly. So you have to have enough solid and robust evidence in cardiothoracic anesthesia to tell them that, yes, I finished my training, I can work as a consultant in this subspecialty, and I'm independent enough, and now I am eligible, or I feel that I'm eligible to be granted a CESR in cardiothoracic anesthesia. The decision came as the committee concluded that Dr. So-and-so has met the requirements of domain 1B, and an audit and clinical governance will be assessed under any other domain, in other domain. So I finished, or to them, I met the requirements of domain 1 in full. And then it's very important just to see what they looking at when they, sorry about that. Okay. Yes. So if you look at the box, the one which is in the middle, which lists the evidence considered in the evaluation of this domain. The first and foremost is the structured reports. Structured reports in the CESR application, they are the most important proof that your evidence is robust and complete. Without structured reports, I don't think the application would be successful by any means. Who writes the structured reports? Your referees are the ones who write the structured reports. You're obliged to have your clinical lead or clinical director as one of them, and the rest of the 5 reports coming from referees that you choose by yourself. So if you look at it from the GMC side, if one of these referees says that he does not believe or does not fully support you in your application, one of the referees that you personally picked, then it's very unlikely that your application will be successful. So apart from the clinical lead, the other 5 ones, the other 5 referees should say and should confirm and acknowledge that the evidence that you're submitting, that all these domains are perfectly met, and you are capable of taking the tasks of a consultant furthermore. So this is about the structured reports. Then they go through your qualification, your appraisals, your logbook, your details of posts and duties, etc. And all these things should have some evidence, and all boxes should be ticked. How much evidence is needed in each domain? There is no clear-cut number, but if they are talking about the annual reviews, for example, they are expecting to have 12 to 15 per year. So if you're talking about 5 years of experience, then you should have something like 60 mixed forms of different things that could support your application. And at the end, they tick the box if the applicant has satisfied domain 1, and at the end, yes. Domain 1, as we know, is the most important domain. Most of the weight is over this domain 1. It's about more than 70 or 75% of the application should be in domain 1. In domain 2, we're speaking about safety and quality, and 3 items here need to be fulfilled. Does the applicant put into effect systems to protect patients and improve care? Has the applicant demonstrate that they monitor and respond to risk, safety, and safeguard the health and well-being of the vulnerable people? And we all know that this is a very important part of our training, is the safeguarding the vulnerable groups, the women, children, elderly, etc. And at the end, has the applicant demonstrated that they protect patients and colleagues and from any risk posed by their health? And again, they refer to your structured reports. They read what your referees will write, and from their testimonials, they will judge, have you fulfilled this item or not. Other things will be still the qualifications, the appraisals, the lookbooks, etc. These, if you notice here, there's a lot of overlap between the domains. So most of these items were already in domain 1. So each evidence that you provide will cover more than one aspect and will tick more than one box in the different domains. There is a little of specific items related to each domain, but generally speaking, your whole application, which is will be appreciated collectively, and your evidence will be judged accordingly. And again, we stress again on the structured reports of your referees. And at the end, they were happy with the evidence I provided, and they said that the applicant has satisfied domain 2. Then we move into domain 3, the communication, partnership, and teamwork. Again, 3 items of importance over here. The communication skills of the applicants, and the communications both with patients and colleagues are within the specialty and outside the specialty. And then the applicant ability to work constructively with colleagues, can delegate effectively, can be a positive role model, has the applicant demonstrated to establish partnership with patients, encourage them to take interest in their health and obtain appropriate consent forms. So during your journey in your work in the UK or outside the UK, you definitely deal with patients. You sure speak with your colleagues within the department or outside the department about some patient care. You exchange mails. You, as an anesthetist, if you go to a pre-assessment clinic, sometimes you write letters. You consent patients for the anesthetic, for the epidurals, for the TUEs, for example. I mean, all these things which are done as a routine counts in the application form. This is something which is close to the surgical consent, but because the surgeons can prove it, while in anesthesia it's difficult for us to an extent, or sometimes we're not used to deal with patients and document what we have done. But over here, the pre-assessment clinic sheets are important. The emails that you send to your colleagues discussing patient care, they are important. And of course, everything should be anonymized, and that goes without saying. Again, what do they look for? The first and foremost, structured reports. Your referees will state clearly that you can work in a team, that you have good communication skills, and if they can demonstrate examples, it doesn't have to be long stories, just that they have seen you or they have witnessed you working in a team, dealing with patient with care, giving informed consent properly. And again, if you go through the whole list, there is a lot of overlap again. And then at the end, you can find the health and safety, the communication with colleagues and patients, as we spoke about. If you had the chance to fill the multiple feedback, multi-source feedback, the 360, or you have done the patient feedback forms, this is very, very important and very useful. If you partner with teamwork, and if you have performed audits, if you have performed or developed guidelines with the team, all these, if it's documented and if you have proof that you have gone through all of this, is very important and will tick that box. And at the end, it was said they were happy and they said they are satisfied. The last domain is maintaining trust. And maintaining trust has 3 items again. has the applicant demonstrated respect for patients and being polite, considerate, and of course, this is you can have it from testimonials from your colleagues or having from the patient feedback forms. The second thing is, has the applicant demonstrated that they treat patients and colleagues fairly, without discrimination? And then at the end, has the applicant demonstrated that they act with honesty and integrity? And in this maintaining trusting across, again, the journey in your work, you will, maybe you have received a complaint, maybe you made a complaint, maybe a patient made a complaint about something. So the way you receive it and the way you anonymize the information, which are quite confidential, and the way that you respond to it is quite important. So this gives an idea about how do you deal with conflicts, how do you respect patients and respect patient in dignity and respect the confidentiality in as a whole. And if you are succeeding in doing this and providing all the evidence about that, again, they will should be happy with this. And here the list is a bit longer. Again, the structured reports, they will mention this, your referees will mention this in their report. And then your appraisals, your research, your teaching, participation improvement. And if we go down to along the list, there is management and leadership experience. Like if you are managing the rota, for example, if you are managing a meeting or chairing a meeting within the department or outside the department, in a conference, any kind of educational or clinical governance event, this is something you can make use of. Acting your relationships again with patient, etc. And if you read the list per se, it's very inconclusive and very, I would say, grayish. And when you start your application, you just think about, what am I going to do about this? This is really, there is no clear-cut form that you will fill that say this box is ticked. But unfortunately, or fortunately, it depends on your perception, this is how it goes. So one document can tick many boxes, and the question is this the right document or not? So at the end, they give you the final verdict. So does the applicant training or special qualification and experience meet the standards of a consultant in any of the UK health service? Yes or no? And then they provide a brief statement about the application in general. And they provide you with, along the application, they will provide you with like samples of what the referees have said about you and what testimonials have been given. And at the end, they will say that the Royal College of Anaesthetists recommends that Dr. So-and-so be awarded the CESR in cardiothoracic anesthesia. This is the trophy of the whole process. So the questions over here, going through this, as we mentioned before, you have to transform your experience and your training outside the UK into a form that the UK authority, namely the JMC and the Royal College, understands. You have to prove that you have enough length of training, enough years of training for this subspecialty. And if they are expecting 7 years of training for the anesthetic in general, and you are applying for this, then you should pay more attention that you need to have more evidence in the subspecialty and more history of experience And this history is documented in the way they can understand. And this experience, again, is a training experience rather than a consultant experience. They are not interested in your consultant experience. This is an equivalence of training rather than anything else. You have to prove that your training equals their training. And if they're happy with all of this, then they will grant you the CESR. One last remark is because if you think about the terminology again, the names or the job titles that we have to be translated into what the GMC understands without changing the titles. So if I say that I was a lecturer of anesthesia, there is no equivalence to this in the UK system, in the clinical UK system. But this is the job title the university gave me. So, and I'm not eligible to change that. I have to list my jobs the way they are from my hiring body, which in this case was Cairo University. And here you will have a chance to explain what do you do? What is the job? If this is the job title, so this is the job description. You will have a chance to do so. And you will have a chance to discuss with the GMC, with your advisor, who initially, or basically, he works with you, not against you. He is the middleman between yourself as an applicant and the Royal College. They have seen thousands and thousands of applications. They know how the Royal College thinks. So they are trying to help, but they are not physicians, they are not doctors, and they haven't worked abroad. So there will be some kind of discussions, sometimes debates, sometimes things that you don't feel it really fits within your experience. But at the end, the authority or the body which will assess your application is the Royal College of Anaesthetists in the UK, not outside the UK. Thank you very much, and I hope this would have been informative, and I try to make it as concise as possible, at least not to waste your time. I know you have seen many of presentations before, and any questions, I'm very happy to answer them.
Perfect. Thanks so much, Dr. Hisham, again, for Professor Hisham to be with us today. I would like to recap in 3 points, then I'll ask 2 questions, and we'll take the questions from our dear colleagues. Here we have 12 colleagues attending this meeting. So the first thing, thanks very much. Your experience here really enriches this series of step-by-step CESR, because we had completely an opposite experience from Dr. Amr al-Sisi. So he was applying for the general application, and after reviewing his application, they advised him to be in the cardiothoracic non-CCT CESR application, and he went from then, and he was successful when he resubmitted this modified process. And you're coming here with completely opposite experience. You submitted for cardiothoracic non-CCT, and they advised you, or they recommended, why don't you apply for the general application? And then you found yourself not in that position, and you justified why you're applying it that pathway, and then it went successfully. So this is really very rich experience in 2 different applicants coming from 2 pathways, completely different, and ended by a specialist registration in cardiothoracic anesthesia. I would really recommend for our colleagues that you go back to Dr. Amr al-Sisi and see his presentation in that regards, and compare these 2 big differences in the application. That was number 1. You mentioned, Prof. Hisham, that higher and advanced cardiothoracic anesthesia training cut forms were your main source of getting the knowledge. So we need to highlight this area. So this is the only evidence they can compare your clinical experience with. So go back to the cut forms in the annex, with the cardiothoracic anesthesia training, higher and advanced training. This is your backbone. Am I right, Prof. Sham? In the clinical,
yes.
in domain one.
Let me reflect on the first point first. So regarding Dr. Sisi, ironically, Dr. Sisi and myself graduated the same year. We worked for the same departments. We had the same pathway, and we had completely two different advices. I think over here, for Dr. Amr, when I saw his presentation, they went through his application, and they found more evidence, or more cardiothoracic evidence in his application that supports the non-CCT cardiothoracic route. The issue with myself over here was the eligibility to start with. They haven't even reached the phase of looking at my logbook or my experience. They were questioning, am I eligible for this route or the other route? And exactly this is what I'm trying to stress over here, that you have this is two persons from the same department with almost the same experience, getting two different advices. So at least you can ask, and you can explain yourself, and you can speak to them at the GMC or the advisor, because again, is not a doctor at the end. He is someone who has great deal of knowledge in the application process, and they are trying to help you according to what they see in the papers. So if you have the right papers for them, then they will guide you through this. If you do not present what do they look for, then they will guide you somewhere else. About the second issue is the cut forms. So if you go through I would say through the general CESR pathway. In the general CESR, again, we are trying to say that I had enough training equivalent to the training that you had over here. So I've done that much obstetrics, that much surgery, that much cardiothoracic, that much everything. And by the end of these years of training, I can say comfortably that I'm a confident anesthetist, independent enough to be granted an equivalent to the CCT. In cardiac anesthesia, if you go through the whole manual of the training, we only have two modules, the higher and the advanced. And these modules have enough knowledge and enough items to be fulfilled. So you have to go through them. And again, they don't know us. They simply look at, this is the reference, this is the evidence that you are presenting. If your evidence goes with the reference, then you're done. If it does not, then the application won't be successful. So, and at the end of each module of this, you get a completion of unit training. So once you get this form, then this means that all the boxes in this module have been ticked. And I heard about applications just going back to the applicant just because of this form was not there. So they had to go to fill the form. They haven't provided more evidence. They haven't provided any more cases or logbooks, just a form that the college tutor said, yes, this person had done all of these competences and he's eligible to have a completion of unit training in this subspecialty.
Perfect. Okay. You mentioned, Professor, that experience more than 5 years still counts. And I have a question here from Arav asking almost the same question. Does the evidence need to be from the years of training in the specialty and subspecialty from wherever it happens in your past 15 years back or 20 years back? So wherever you had that experience, you submit it, or it needs to be 5 years only, or both can be submitted?
Well, again, if you look at it from the GMC and the Royal College point of view, you are applying for non-CCT, cardiothoracic, anesthesia, CESR. So this means that at least in the last 5 years, you have been practicing cardiothoracic anesthesia mainly, and you have evidence to prove that. But because we are applying at different stages in our career, so if you are applying for a non-cardiothoracic CESR, then they will ask you just to delete any evidence which is more than 5 years old. In cardiothoracic, because this is a subspecialty, this is a post CCT specialty, then they know that your training was more than 5 years old, and after you finished your training, you trained in cardiothoracic anesthesia for some time, and then you're applying for that. So in that case, yes, they do accept that the evidence will be more than 5 years. How far in the past is it? I cannot say, of course, and because at the end, it depends on the evaluator. He is the one who's gonna look at the file and say, yes, this evidence is accepted or this evidence is not. But generally speaking, more than 5 years is accepted.
Perfect. I have a question about your research publications and presentations, Prof. Hisham.
Yes.
And this is a very common question I'm getting almost every day. Are you requested to submit a research in the term of a randomized, controlled, or observational trial in your application to get that box ticked, or audits, case presentations, poster presentations should be enough?
First, you have to know the difference between research and audit. Audit is a quality improvement project. Audit simply replies or responds to the question, is what we're doing at the moment goes along with the standards or not? It's not research. And by the application, by the Royal College, by the training, you are requested to do audits at least every year. Audits can be massive audits or just minor ones, departmental or whatever the level. What we need to stress on is to have a closed audit. Means that you have done an audit, you found somehow the gap between what we're doing and the reference, and then you did the teaching, and then you re-audited the practice, and this gap got closer.
Full audit cycle. Yes.
Full audit cycle, exactly.
Yeah.
In research again is a very wide spectrum. It starts from case reports up to systematic reviews and meta-analysis, with everything in between. You don't have to do complicated research to be accepted, but you have to be at least interested, or at least tick a box. So you can. It doesn't have to be a research, multi-center, international thing. But if you do an observational study, yes, this ticks the box. If you write review articles, if you write case reports, if you share in a randomized controlled trial, all of this can tick the box for you. Again, there is no number, I would say, below this number, yes, or above this number, you never know. But at least audit is an ongoing process. Research is something that you can do, whatever the complexity of the research.
Perfect. Okay, so I have a question here from Dr. Ajith. How many letters to GP or to colleagues would be expected to be submitted as a proof of communication skills?
I asked the same question and I got no answer. So yes, and even I asked the college tutor in my hospital when I was working at the Brompton, and she's very helpful. But again, what the GMC and the Royal College says if you submit one form, it's eligible for bias. But if you have like 15 or so, from 12 to 15 forms or letters, this is less likely to be biased. So again, you cannot say that this, you have a threshold or you have a certain number below which your application will not be successful. It doesn't go like that. And definitely, I would collectively say, if you apply for the CESR, for example, if you have enough experience outside the UK, and then you move to the UK, and then you start your job in the UK, and then you apply, at least you will, within the UK, you will have at least not less than a year or 2 years before you feel confident enough to submit your application. And during this year or two, or whatever, you definitely come across these letters, whether they come to you or you intentionally write them to your colleagues because you're applying for your CESR. And as an anesthetist, definitely we'll find ourselves in the middle of a debate or discussion or whatever, that this patient needs ITU, this patient needs that, this patient is ready for the operation, this patient is not ready for the operation. I mean, these kind of discussions, these are the letters that we look for.
Perfect. Ashish, thanks for coming again and again. One of the regular guests interested really in this. He has a question. I think he's interested to ask that verbally to yourself.
Yeah, sure.
Ashish, please go ahead.
Good afternoon, Dr. Islam. Thank you for your time and enlightening us. My apologies, I just joined very late in your lecture. And please excuse me if my queries have been answered in the initial part of your lecture.
No worries.
Like I could understand, you said that the benchmark of the evidence which we will be submitting is the higher and the intermediate modules.
The higher and advanced.
Higher and advanced.
Yeah, higher and advanced.
Yes.
Okay. So does this means that we have to submit evidence only in cardiothoracics and not in other subspecialties like obstetrics, neuropediatrics, if we are applying for non-CCT CESR in cardiothoracic? Well,
it depends on, to answer your question, what's your main target? Are you applying for cardiothoracic anesthesia CESR? Then you have to tell the GMC and the Royal College that you finished your training, the higher and the advanced, in the subspecialty that you're applying for. Your evidence, your general training, anesthetic training evidence will still count, even if it's years ago, more than 5 years. But definitely, to apply, you need to have finished your general anesthetic training somewhere in your own country or whatever. And of course, you will provide evidence that you have done all these modules that the general anesthetist will do.
Okay. Like I finished my anesthetic training back home in India. That was almost 10, 12 years back. And since this last 10 years, I've practiced exclusively cardiothoracics, including a fellowship from India. So I have 10 years experience of cardiothoracic, but zero experience in non-cardiac work after my post-graduation. So that means I will have some problem in collecting the evidence.
Well, let me assure you that my general anesthetic training ended in 2001, and they accepted it.
And after 2001, you did not do any non-cardiac work?
I've been, more than 90% of my work was cardiac.
So that is the same story with me.
Yeah. So, and it was accepted by the GMC and the Royal College.
Okay. And another thing which you mentioned a few minutes back,
yes,
is that even if you have done a lot of work outside UK, but you still need 1 or 2 years of cardiothoracic experience in UK.
I think, let me rephrase it this way. I mean, if you are planning to do your CESR from outside the UK, what's the point to start with?
I am in UK now, so let's talk about
I understand, but I mean, first, because it's not completely about your knowledge and skills. All of us are well trained, and all of us has wide range of experience.
Correct.
The non-clinical aspect of the practice, which is the very important one, and if you go to your appraisals and revalidation, which are important documents in the application. I'm not sure about the situation back in India, but definitely, if I'm talking about Egypt or the Middle East, where I worked before, we don't have this formal way of appraisals or revalidation or patient feedback or multi-source feedback.
Yeah.
Again, you're applying for registration in the UK, so you have to speak the UK language. You have to bring the UK documents.
Okay.
So this will take some time.
Okay.
I can assure you. I'm sorry, Ashish. I can assure you, Prof. Hisham, if anyone seeks advice later on in this point particularly, I did my complete CESR application from Ireland with the same language British system talk. So everything, appraisals, cut forms, everything. I found people interested in what I'm doing to sign my forms, and the appraisal was done via a company, a private company in United Kingdom that did my appraisals. So I have 45 pages appraisal and certificate of appraisal for the last 3 years via my general registration. And here I need to highlight one point. You need to be in the general registration. You need to maintain your license valid, and you need to maintain your designated body, and that can be done even if you're working in Egypt or India or anywhere in the whole world. And you can hire these private companies. I'm not advertising anybody, I'm not saying any names here, but you can hire any of these private companies so they can do your appraisal process. And I highlighted that in the previous lectures. It's extremely helpful. And when you go through this appraisal process, you're actually speaking the same language of the General Medical Council. You need to do a personal development plan. You need to reflect on your CME hours or CBD points. So they take you via the process in 14 different steps, the same language of the General Medical Council. They are asking in your application at least for 1 appraisal report. I made 3 in my application. It's very helpful, yet it's a bit costly process. Ashish, go ahead, please. And if you want to reflect after that, Prof. Hisham.
Yeah. Okay. So if I give myself 2 years of UK cardiothoracic experience, then would you suggest these 2 years, both of these 2 years as fellow, or one of fellow and one as locum consultant?
Again, it is very important. They are not interested in your consultant work, and it's clearly written in the guidance. You know that for the trainees, they can be accepted for locum consultant if they are within the 6 months of finishing their training. But this is not the thing that the majority of the evidence will be based upon. They are looking at your training. The locum consultant job will tick the box of independency. So it will say that Dr. So-and-so can work independently, and he can manage the list, he can manage the communication around this, he can manage the staff. Yes, but per se, it does not tick the box that if you are a locum consultant, then you get the CESR. It doesn't work like that.
Okay.
Dr. Ashish, are you finished with your questions?
Just one last thing. How is it important to work in a transplant center, or it can be any cardiothoracic center?
Again, the higher and the advanced module does not say that it has to be a transplant center. No. Okay. It has to be, I would say, straightforward cardiac center doing more or less straightforward, plus minus complicated surgeries. And again, I refer you back to the modules themselves, because it's clear in the modules what boxes you need to tick. Yeah. So the higher module more or less focuses on the clinical work. The advanced one focuses more on the independent work and how you manage the list, but it does not has to be in a transplant one.
Okay.
Perfect. Thanks,
Okay,
Ashish. Thanks so much. I'm sorry if I cut your voice, Ashish. So I have a question here from Ajit Baburjan, if I pronounced the name right.
Sorry, but let me recap again about this, because I would refer Ashish to speak to the GMC about this in particular, because when I did my fellowships and the locum consultant, I was in a transplant center, so this box was ticked automatically. But again, if you have any question or anything which you don't feel it is clear enough, just write them an email or give them a call. I would recommend email because it's a document at the end, and get this point well clarified.
Perfect. I think you're the third or fourth consultant highlight the same issue. You have to have an evidence on your chats with the General Medical Council, so you can use them later on while you're applying or in the time of your application. Two questions to end with. One from Ajit is, if my training or his training or her training, I'm not sure if that's male or female name, I'm sorry for that, my apologies, was long time ago, and it's impossible to get a completion of unit of training for, because it's 10 or 15 years ago. Would it be okay or right to do my workplace-based assessments and cut forms to be repeated now while I'm working as a consultant? So I will do extra work hours as a reg and get myself supervised, if this is my right understanding, and I will get these forms ticked. Will that be the proper pathway, or doing my consultant list now and do my application via solo forms or solo lists, something like that, will be a more proper given my position in the moment? What do you think?
This is again a very individualized situation. What we are talking about here is, can you provide the document or not? They don't know us. There is no direct contact. There is nothing but papers going from ourselves to them and getting it evaluated and returned back to us. So they just evaluate the paperwork. So if you have the paperwork, or you can get a description of this cut form from the institute that you have trained in, even if it's in the past, that can describe the that can describe your training and the level of training that they achieved, this is well and good and will save you time. If not, then I think referring back to the GMC and getting their advice would be the most advisable thing to do.
So I have a last question here, which is very sensible in your occasion after you got the CESR specialist registration via CESR pathway in cardiothoracics. So you are now on the specialist register as a cardiothoracic anesthetist. Will you be able to do general anesthesia locum jobs or general anesthesia permanent job in your hospital, or you will be strict? Like we are really re-emphasizing and highlighting this point with one after another. Are you like strict on doing cardiothoracic anesthesia now if you are interested to do some locum jobs or permanent jobs in other different specialty, anesthesia specialty?
To the best of my knowledge, there is nothing which prevents you from doing non-cardiac work. The specialist register doesn't say that you are a specialist register in cardiothoracic anesthesia. It says that you have done your CESR through the non-CCT cardiothoracic pathway, and it's between yourself and the hospital to decide if you can do that or not. Of course, I would say the experience that I saw from friends and myself, sometimes you may find yourself doing vascular or radio or general a general anesthetic practice, general surgery, whatever. And there is nothing from the management that says you should not do that. If you're talking about applying for jobs, then it will be your CV against the competitors. So, but a clear no, I haven't seen a clear no against the applicants with cardiac CESR doing non-cardiac work.
Okay, last question again from Ajith. Correct me if I'm wrong, please. Did you say that you had your basic anesthesia training a long time ago, and because you applied for cardiac, you did not have to submit evidence of general anesthesia? Is that your scenario?
I did not have to submit. Yes, what I did was I got a description of my residency program, my training. I got what I could find from the books back home about my practice through this time, because definitely there are register for everything. It is not as accurate, definitely, as the one you're using now with the Royal College or whatever the software. But most of this was accurate. The problem is, or I wouldn't say that the problem is, if you don't have evidence at all, then how are they going to evaluate your application? So there must be an evidence. There must be a description of your training, and there must be something which supports this from the clinical point of view, which is a logbook or the collective logbook. It is difficult sometimes to get that, because you have to go back and ages and dig in the books. You might find them, you might not. Maybe if you keep some work within this time of non-cardiac together with your cardiac, it might help. I cannot say yes or no in this perspective, but this is what I did.
Perfect. So the last thing I would like to highlight, again, you mentioned that point in particular, Professor, that you have to nominate or put the names as you got them, not as they are in the General Medical Council. They are a bit different, but you need to explain the names. A very good example for that, in our countries in the Middle East, like in Gulf areas and Egypt, they call the specialist for the registrar. So if you said, I worked as a specialist in anesthesia for 5 years, you have to explain that this specialist means this job description, and you explain that by job description, so they know that you have a backup or you have someone higher in your hierarchy who is the consultant. Because in United Kingdom, they call the specialist register as a consultant. So it's a bit different meaning, but you cannot say, you cannot rename yourself as per the British names, because that's not what you had, and you cannot have a document supports what you say is as per the British names. So again, use what you got, but explain with the job description, and this is why they need your CV to be submitted. So this is the job I did, like a resident, and residence means this job description, so they will understand this resident name is entitled to something like a senior house officer or a SAT1 in their scheme. But you cannot say I was SAT1. If they ask you the evidence of what SAT1 in your system, you cannot bring that from your home university, because there is no SAT1. So you just created that out of the blue and put that thinking that may accept that because this is the name in their system. And I think from the journey of my communication with the medical council, they are very meticulous with nomenclature. So use what you have in your evidence, not what they have in their system. Am I right with that, Professor?
You're completely right. So just think of it this way. If you can provide a document with what you're saying, use it. If you cannot, don't. So, and especially if we're talking about myself and maybe for Amr as well, because we are coming from a university, so we have an academic titles. And if so, I had to list my titles the way they are. I could not change them by any means because this is the formal document which the university issues. And then when I had the chance to submit another document that says if the resident is equal to this job in the UK system, like core trainee or so, and the job description of which is 1, 2, 3, 4, and then the assistant lecturer is equivalent like an ST 3 or 4, for example. And then after you have an MD degree for the first years after the MD degree is equivalent more or less like an ST 6 or 7. So yeah, you will have the chance to explain, yes, but you cannot change the terminology.
Fantastic. So thanks very much, Prof. Hisham. It was fruitful discussion. It was like really rich discussion about cardiothoracic anesthesia non-CCT CESR application. Please accept my virtual bunch of flowers. And,
thank you very much.
We
really
hope to see you
enjoyed it
again.
And
thanks so much.
I hope it was beneficial for the group.
I believe it was very beneficial, at least from the feedbacks we are getting here verbally from those people really interested in non-CCT in cardiothoracic anesthesia. So I really appreciate your presence and your time, particularly in the morning of the weekend. Thanks a million. Thanks for our colleagues, attendees today. And for whoever missed this session, recordings will be available as soon as the montage is done for these videos, and it will be available on Prof. Hisham Hosni YouTube channel as well. So it's dual publication for all our colleagues from here and UK and everywhere in the whole world. Thanks very much for being here today, and wish you a pleasant weekend if you are in the weekend still. Thanks a million.